Tonight, we're also going to be speaking about the number 4 there, and we have a very, very special guest with us tonight. And in a minute, Sherry's going to introduce him. But it's, again, about knowing, finding your way through the maze of the healthcare system and knowing what to do. And I think, really, if you're unaware and if you're ignorant about your way about the healthcare system, I mean, that can get you in trouble. You just can't leave number 4 out of it if you want to live a healthy lifestyle. And the perfect example is toothache. Let's say you have an impacted tooth. Well, no matter of positive thinking or having a good nutritional supplementation or even exercise is going to take that toothache away. It's basically going to ruin your life. That's going to be your number 1 focus day and night until that problem is relieved. And, well, bringing it closer home, I think it's even with regards to feet, and that's what our talk is on tonight. But this really came to my focus and became an interest of mine when I met, well, let me show a picture of the 4 of us. These are the racquetball players. Anytime you hear me talking about racquetball, I just came back from a racquetball game. I've been with these guys. These are the 4 horsemen in the war zone, what we call the war zone, and that's from the left to the right. Here, left to right is Burley, me, that's Dean, and we'll talk about him in a minute, and of course I'll present it today. Here's another picture. Okay, well, you see, guys, I was crossing my hands, and Mark said, no, that's a great pose. I need to cross my hands too, so he basically copied what I did. But anyway, Dean is that's the guy in black. He about 20 years ago, 1988, he was going to quit racquetball, and he loves racquetball. He plays racquetball every day. He's a really, really good player. But he developed severe back pains, and he basically he could hardly walk, much less play racquetball. And he decided to go to a foot doctor. Now, that's the question I would have. I'm thinking if I have back pain, I would go to a chiropractor first. But anyway, he goes to a foot doctor, that's Mark. And Mark was, of course, going to explain to you what he did. But bottom line is 1988 till today, that's 20 years. That whatever Mark helped him to do, what enabled to pretty much save his racquetball career, and he's still playing racquetball with us today. So there is a lot to be said for what goes on in your feet, as well as anywhere else. And tonight, it's all about that. So we're going to be talking about this. And I'm going to have to ask Sherry to introduce, in my estimation, one of the most intensely competitive, and I can't believe I'm saying this, but one of the most talented racquetball players I've ever played against. You can pay me later, Mark. But Sherry, go ahead.
Okay. Before I introduce him, though, Mark, I've got to ask you how to say a certain word. Is it podiatric? Is that how you say it?
Podiatric.
Podiatric. I have trouble saying that word, and in your bio, I have to say it about 10 times. So I figured I better.
Everything's got the word.
Podiatric. Okay. So, it's Nahmias, has been in private practice for 21 years in Tulsa, Oklahoma. He earned a BS in microbiology from the University of Oklahoma, his Doctor of Podiatric Medicine degree from the California College of Podiatric Medicine in San Francisco, California, and completed his surgical residency in Houston, Texas. He's presently board certified by the American Board of Podiatric Surgery, by the American Board of Podiatric Orthopedics and Primary Podiatric Medicine, and by the American Academy of Wound Care. He is a fellow with the American College of Foot and Ankle Surgeons, that's much easier to say, in the past, and is the past president of the Oklahoma Podiatric Medical Association and past president of the Oklahoma chapter of American Diabetes Association. Sounds like he's been a busy guy. Mark is married with 3 children. I actually found out before the webinar they're all boys. And his hobbies include playing racquetball, which you just saw a picture of, and golf. So, Mark, welcome. We're so glad to have you here tonight.
I'm happy to be here. That is a mouthful, a lot of podiatrics.
It is, and I was dreading that word.
Not necessary. I'm very happy to be here. I do welcome questions, and I've never done anything like this before. I give a lot of talks for the American Diabetes Association. I live in Tulsa, Oklahoma, and I travel around sort of the four-state area and give a lot of talks. I did a lot of talks when I was president, but I enjoyed it. I'm not a diabetic, but as you'll see in my talk, diabetes is a major part of what I take care of. Probably 40% of my practice is diabetics, but I consider myself a generalized podiatrist. Podiatry is basically the study of the foot and ankle. The license of podiatry depends on which state you're in. In Oklahoma, we are licensed to work on the foot and ankle. Some states are licensed a little higher up than that in the leg. Some are licensed not as high. In Oklahoma, you're required to have at least a 1-year residency after 4 years of undergrad and 4 years of podiatry medical school. So it's quite an extensive study. I believe that the podiatrist offers really the best insight into treating feet. I mean, if you have a heart problem, you go to a cardiologist. If you have an orthopedic problem, shoulder, wrist, back, you go to a specialist in that. But I don't feel that there's anyone else that's really qualified as well as a podiatrist to specialize in the feet, perform surgery on the feet. I do perform a fair amount of surgery, and like I said, I'm sort of a generalized podiatrist in that I do pediatric podiatry, some geriatric stuff, dermatological things, sports medicine. I do a lot with biomechanics, and we'll talk about that. And then I do a lot of trauma. My residency, I worked a lot through an ER, and we had a lot of trauma, so I'm real familiar with that too. So I've kind of prepared some slides that cover a few things. I do more talking, I think, than showing slides. But again, I welcome any questions. I am a member of the American Podiatric Medical Association. Several of these slides are from that organization. I believe that you should support your national organization, both for education purposes and also political things come up. And nowadays, with medicine changing so rapidly, you really need to have a voice in Washington. And the APMA it's just like the AMA, except we're podiatrists, and we work very well with a lot of other types of physicians. A lot of what I do also is a team approach. As you see some of these slides, you'll notice that it's the foot part of the rest of the body. David mentioned, everything being integrated. I think that's a big thing. I consider myself sort of a team member of the foot aspect of the rest of the body. I work a lot. I work a lot with vascular specialists. I work a lot with internal medicine specialists, especially when it comes to diabetes. We have a diabetes medical management person, and I'm usually called in to take care of the feet, whether that be something simple like palliative care or something more major like amputations. A lot of interesting facts occur when you start thinking about feet. I think people really don't think about their feet as much as they should. And when you look at some of these facts, people nowadays are very active, and they want to stay active. And one of the ways you stay active is by being on your feet. You don't really think about your feet until you just don't have them anymore. And a lot of people, and most people, I would say it's general human nature to put things off. They put things off until they just can't do whatever it is they want to do. It's kind of a joke in my office, and I'm in private practice. So a lot of what I tell my assistants in the office is find out what it is that makes people come in. Why are they here today? Someone that's had a problem for months and months, and then they waited until that day to come in. What is it that makes them come out that day? I'm very big on exercise. I'm very big on walking. And people, to me, and the number 3 down there, the studies that show that older people who continue to have active lifestyles experience less health problems as they age, a lot of that has to do with taking care of their feet. People don't realize that most injuries are preventable, and most things that happen with the feet are preventable. So that's kind of what I do. The foot is kind of complicated. It does impact your ankle, knees, hips, and back. 26 bones, 33 joints, and lots of ligaments. We mentioned my friend Dean, who we play racquetball with, who's an older guy. It's interesting because I've known him for a long time, but I first knew him as a patient, and he came in to see me because he was having some back pain. I don't treat backs, but a lot of back problems, the pathology has a lot to do with the feet, and the way the feet are affected can have something to do with both the knees, hips, and even back.
Do you know why he decided?
I'm sorry. Some of the problems. Go ahead, Dave.
Go ahead. Sorry. I was going to ask you, do you know why he decided to come to a podiatrist instead of someone who deals with the back?
Well, you know, a lot of people have a pretty good intuition, and they'll have a problem. Sometimes they'll have more of a problem with their back, say, in their bare feet, or they have more of a problem with their back if they're doing you know, only when I'm walking or only when I'm wearing these shoes, things like that, where you know, people are enough intuitive to say, hey, I think this may have something to do with my back. And then sometimes we'll see people that have been and had their back looked at, and they get a clean bill of health and they can't figure out what it is, and they'll come to me. And granted, again, I don't treat backs, but sometimes in the foot, the way the foot pronates or the way the foot rotates, and we'll talk about this a little bit, has a lot to do with the stress that's placed on the back.
Got it. Okay.
Okay. Some of the things I'm going to talk about, obviously some of the things that I see, arthritis, bunions, hammer toes, heel pain. There's diabetic complications, sports medicine and sports medicine industries. I don't usually talk much about nail dystrophies in a general thing, but a lot of times nowadays all the advertisements on television for different medications, some of the antifungal medications are discussed pretty prevalently, and I'll talk about that. And then last but not least, some of the trauma. I myself have had a pretty serious foot injury. Ironically, in my residency, I took care of everything from people having shot themselves in the foot to lawnmower accidents. And then my first year out of residency in my own backyard, I tripped and fell and ran over my own foot with my lawnmower. So I'm quite the expert on lawnmower trauma, even though I have all my toes and walk well, and you couldn't even tell. I'm going to start out talking about biomechanics. And biomechanics is a little bit of what we were talking about with my friend Dean. The biomechanics are basically the way the foot operates. From the minute your heel hits the ground, the position that your heel is in determines the way your midfoot is going to contact the ground. And then as your foot rotates over and the ball of your foot comes on the ground, your foot's going through a motion called pronation. Pronation is where you roll the foot over towards the medial or inside, and then as you push off, your foot has to become a rigid lever, meaning that your foot, if your foot is flexible, it flexes out completely, and then it has to go from being a shock absorber to a rigid lever, and you have to push off of it, because you wouldn't be able to push off of a foot that was very flexible. It would just be flaccid and you would fall. So biomechanics is the study of how the foot operates from the minute your heel hits the ground. And I also tied this into sports medicine because a lot of people stay active with running, and when you're running, different kinds of shoes do different things to the feet. So you have to be sure that you wear the right kind of shoe that's made out of the right kind of material for a foot that is designed for a foot that's going to be going through running or walking, which I highly promote the walking. Some of the common sports-related foot and ankle injuries that we see, obviously skin problems concerning of blisters, athlete's foot, warts, and then excessive sweating. Living in Oklahoma, a lot of what we see is somewhat seasonal. As we go from winter to spring and spring to summer, the more the foot perspires, the more you're going to see blisters, athlete's foot. Athlete's foot is a fungal infection of the skin, which may sound fairly obvious. It's just that type of problem is more prevalent when your feet sweat a lot. Simply using some over-the-counter antifungal powders can really stop blisters and athlete's foot, as well as excessive moisture and sweating. Warts are a viral infection, and they are caught either by showering in a place where someone else has a wart, and then you catch that wart. Plantar's warts are most definitely the thing we see the most commonly. Plantar's warts are much different than, say, a regular wart, which you get in your hand or your skin and somewhere else. Plantar wart, the word plantar, means bottom of the foot. And so a plantar's wart is more serious because the skin on the bottom of the foot is thicker than anywhere else in the body. Therefore, that wart invades the deeper layers of the epidermis, that outer layer of skin. And when it gets into the deeper layers, it's much harder to get rid of, which is why plantar's warts are so hard to get rid of. Let's see. Well, I'm having trouble with my slide here for some reason.
You might have to right-click on it. If you right-click on it, that might work. Try the arrow.
Yeah. Sorry about that.
Okay, there you go.
Yeah, I remember. I got it now. I'm not the. It's still with the right arrow. Won't let me.
Okay. Well, okay. There you go. that works.
That's still not going.
Still not going. Huh. Okay. Is there any ideas?
Well, it seems like you've tried all of the options.
It says PowerPoint could not create a hyperlink to.
Have you tried in the bottom left-hand corner?
I did that. Let's see.
I mean, worst case, Mark, is just close it out of slideshow view, hit escape, and then just start the slideshow view again.
Okay, good idea. There we are. Sorry about that. I'm not as think as you dumb I am, though. It's okay. Anyway, thank you. Some common sports-related foot and ankle injuries, much more serious than the skin problems that we see. Obviously, the list are ankle sprains, muscle strains, tendonitis, plantar fasciitis, which is how that's pronounced, nail injuries, runner's knee, and shin splints. When you have an injury, it's something, in my opinion, that you really got to get looked at immediately. Everybody has that old thing about walking off an ankle sprain or a muscle strain. To me, it's not real bright, especially if you're trying to stay in shape. If you have an injury and it goes unaddressed, it will continue to get worse, and then whatever the activities that you want to do, you will most definitely not be able to do that. So I believe that when you get an injury, you shouldn't take it lightly. Even if it's something very simple, don't ignore it because it's not going to go away. I think shoe gear is a big thing when it comes to prevention of injuries. You'd be surprised how many people come into my office that run that have worn out shoes or old shoes. No, I don't necessarily believe there's a specific amount of time to keep a shoe. I do believe in rotating shoes, but I think sport-specific shoes is important. For instance, running, wear a running shoe. Walking, wear a walking shoe. Now, that sounds like a little childish, but you don't run in a walking shoe. And running shoes nowadays, with the high-tech stuff that are put into these types of shoes, walking is not good to be in a running shoe because you tilt your foot over more than it should in a running shoe as opposed to a walking shoe. Plus, I think it's difficult these days when these shoe companies recommend a particular shoe. If any of you out there are runners, you know that you buy a shoe or two pairs of shoes, and then when the shoes wear down, you go back to the store and they've discontinued that shoe and they've got an upgrade. Not only are they charging more, but the shoe isn't the same. So my advice is buy a couple of pairs of shoes when you're going to be getting a sports-specific type of shoe. Obviously, wear good socks, wear the socks that are appropriate for that particular activity. We'll talk about orthotics or insoles in a minute, but when I speak of orthotics, I speak of custom-made orthotics, not over-the-counter orthotics. I am not a big proponent of generic type of orthotics. Each person has a specific type of foot. That type of foot is what they inherited or what they were born with, and those types of feet have certain inherent problems with them that lead to further problems down the line. Many of you that have a bunion or a hammer toe or know a relative, an aunt, uncle, grandmother, somebody who's had that, you may see your foot changing. And not that shoes will prevent that type of thing, but you've got to take shoe wear seriously. And as far as prevention of injuries, simple things like running without shoes, which I see a lot, causing blisters, causing calluses, most of that is sort of common sense type stuff. As far as shoe selection goes, these are a couple of guidelines. I usually say the thumbnail from the end of the toe to the end of the shoe, or at least from the end of the longest toe to the end of the shoe, is pretty good. If you have two different sized feet, obviously fit the larger foot, but fit the shoes in the kind of sock you're going to be wearing when you wear those shoes. We say fit in the afternoon because a lot of people retain water and their feet are more swollen at the end of the day. I have a service in my office when I recommend shoes or talk to somebody about shoes. We send them to a shoe store and we say, look, don't wear them. Come in, let me take a look at them, let me fit them. Now, obviously, most people can fit their own shoes, and these days a lot of shoe stores are very good at fitting a specific type of shoe. So, you know, a lot of times you can go by what they say in the store, but those are really just some guidelines. And then, again, we talk about walking, running, cross-training, a specialty shoe for a particular type of thing. Materials, I'm a big leather fan. I think leather allows the foot to breathe a lot more, but nylon is the most common material. Some of the newer models are stretchable, and they will accommodate different foot deformities. I do think it's important to have a shoe that breathes. Therefore, your foot doesn't get too hot. Nylon just really tends to keep the shoe, your foot a little bit hotter, and we get back to using powder in the socks daily, which is a good way to keep that under control.
Doing it again.
Yeah, I think I'm sitting too long here on but I'll whip through these. I can do it. Here we are. This is a slide I put together to talk about orthotics, and I've shown there several different types of orthotics. In my office, I used to make my own orthotics. I don't do that anymore because of time constraints, but I use what's called the ROOT, R-O-O-T method for establishing the neutral position of the foot. And I'll use my friend Dean as an example. Dave talked about Dean real briefly, and what Dean had is an incredible amount of pronation on his foot, meaning that when his heel hit at a straight up and down direction, as his foot rolled over and the ball of his foot came down, he actually rolled over or pronated much more than he needed to. His foot maximally pronated, which is the shock absorbing portion of the gait cycle, and because he maximally pronated, it actually rotated his rear foot and his ankle in. And I did a strapping or a taping of his feet to put him in what I call the neutral position. That's sort of the ideal functioning position to be in. And what happens is when I put that taping on, it limited that pronation, which took stress off his ankle, and for him and a lot of people, it took stress all the way from his feet all the way up to his back, because as he rotated, and the best way to think about this, as he rotated over, his leg actually became shorter because he had a lot of pronation. So when his leg became shorter, it was harder as he lifted it off the ground for it to come back to its normal position. And when I made an orthotic like these here, this is a sports orthotic. These are basically an accommodative orthotic, which I'll talk about, but these are the different kinds of orthotics. And what we do with orthotics is we limit the motion of the foot in the proper plane. People that have bunions have a muscle imbalance, and we can actually take these orthotics and use the orthotic to limit the muscle imbalance to slow down the formation of a bunion. We treat diabetics with an accommodative orthotic. Let's say they have a prominence on a bone which will become calloused and can turn into an ulcer. We take a mold of the foot with that impression, and therefore we make a custom-made accommodative orthotic to accommodate that lesion so that the pressure point will no longer be there. Now, this isn't when I'm talking about stepping in some foam in order to get an impression of the foot. I'm talking about putting the foot in a corrected or neutral position, which allows me to take a mold of that in the exact form of where they should be functioning. And that's an example of what biomechanical functional orthotics are. You know, these are not the orthotics that you buy at the fair or down at your local shoe store. Nothing wrong with generic orthotics. Some people do real well with generic orthotics, but when you're trying to get a specific function with a device, you can't do that with a generic device.
So this pretty much corrects it corrects the position and walking, the movement of the shoe. It's a conservative way to do it, right?
Yes. Yeah, the contour is actually made to be perfect for the bottom of the foot. It's the positioning of the rear foot to the forefoot that is what's important, because the way the foot functions, you know, we're taking this foot and we're controlling the function. Now, what I do in my office, I don't just make orthotics for people. We're designing a foot insert to do a specific function for that foot. Some people have very high arch, rigid type feet which need more shock absorption. Some people have very flexible feet which actually need more control. Achilles tendon function, a tight Achilles tendon function, or what we call a pump bump on the back of the heel, is greatly affected by the way the foot functions. And so when we alter the way the foot functions, we're actually altering everything from the knees, the lower leg muscles, the intrinsic foot muscles, and that's basically one of the things that we use orthotics for. These pictures of these bunions, the bunion is, when I'm talking about a bunion, I'm talking about this bump that's on the side of the foot. A tailor's bunion is often on this side of the foot over here, but for the purpose of this discussion, this is a malformation of the way the bone, which goes back in this direction, it used to be straight up and down, but it actually moves over this way. I'm going to show you some diagrams of that, and that's caused by a muscle imbalance. So you don't wake up one day, I use that with my patients, you don't wake up one day and say, hey, there's a bunion. This happens because of the way the foot functions. These hammer toes that are on the other side here, again, a muscle imbalance where a tendon becomes more powerful, say on the top and bottom, causes the toes to do that. Symptoms of a bunion, and that's the bump over what we call the first metatarsal phalangeal joint, the base of the big toe. Symptoms include redness, swelling, or pain, restricted or painful range of motion. Bunions are caused not by wearing bad shoes. Bunions are caused by that imbalance that I talked about. Here's an x-ray, that bump that you saw before. This is a diagram or a picture of that, where this first metatarsal bone has actually gone from a position here and moved out over here. There's basically 4 stages of a bunion, and some of this is very old school, but I like to stick with things that people can understand. This, and Dave, can you see this on there where my arrow is?
Can I see it where?
Can you see where the arrow is on here?
Yeah, sure I can. Yeah.
Okay, I just wanted to be sure that was coming across. The first metatarsal, which is this bone, and this is the bump on the bone. First stage of a bunion is that there's a bump. Not too many people come in at that stage. This is basically an enlargement of the head of this bone. Stage 2 is that the angle that these 2 bones make with each other changes, whereas the metatarsal starts to move from over here to over here. That's measurable, and we know what the normal angle of measurement is, and we can measure that and see how far out that has moved. Stage 3 is where the big toe, in this instance on this x-ray, it starts to move this way. And a lot of people with a bunion will get the big toe smashing up against the second toe. The reason that's important is because there is a change here at this joint. Normally the toe would be here, but as this bone moves this way and the toe moves that way, this joint no longer lines up, and that's a condition stage, is when, because the joint doesn't line up anymore, an arthritic situation occurs where because the joint's not lining up, it's going to always turn into arthritis. And we talk about limitation of the range of motion of the big toe. When moving your big toe up and down hurts, that's basically the arthritic stage, and that's stage 4. They are progressive, and I tell people, everyone that has a bunion, everyone, will form arthritis in the joint. I have 17-year-old patients with severe arthritis. I have 90-year-old patients with very little arthritis. It gets back to those stages, which stage you're in. They're a symptom of shoes, but they're not caused by shoes. They're just aggravated by shoes. I offer different types of treatment for a bunion. Basically, it has to do with treating either conservatively or surgically. Some of the conservative options, obviously after we take x-rays, you can pad the foot and tape the foot. Anti-inflammatory medications or injections are somewhat useful, but not really. Physical therapy really doesn't play a role in this, although orthotics do and changing shoes do. Orthotics we use as a prevention. You know, we talked about putting the foot in a certain position. The malforming, deforming forces, if you will, of the tendons are what cause the bones to change position. Therefore, we use an orthotic to slow down the movement of the bunion and keep it from getting any worse. People often come in the office and say, look, I want to have surgery, I want to have this fixed, but I can't do it right now because I can't take off work. Well, what we can do is make an orthotic so that it doesn't get any worse, and we can slow the progress down so that when they decide to have it, it's not to those severe cases. Surgical options. One of the options is removing the bony enlargement. There are multiple different kinds of bony procedures to fix a bunion. There's over 50 different kinds of bunion procedures. So what one person had or what your neighbor had has nothing to do with what you're having. Simple bunionectomies, metatarsal head procedures, base procedures, and then finally joint destructive procedures are labeled that way as a salvage type procedure. In other words, we're going to do the best with what we have to work with. Simple bunions obviously recover very quickly. The more complicated the bunion, the longer you've had it, the recovery time is much more.
So when you remove a bunion, are you thinking about removing part of the bone or just the soft tissue that's hardened around that area?
Well, if you look at this next slide, it's somewhat self-explanatory. This is a procedure here. This is sort of before and after. You can see this is really the same foot. And on this is what we call a late-stage bunion, where the cartilage is going this way. This person had a wedge removed here. When that wedge is removed, the first metatarsal bone moves back over here. So we're actually correcting the position of the bone both through this joint here and back in here. And that's what gives us this realignment. Now, this is a more complicated type bunionectomy, but the result is the same. Whereas this, and when someone has a bunion, and people that have bunions know what I'm talking about, this gets red, it won't fit in the shoe. I mean, usually this big toe will be way up against the second toe, and you know, when that starts happening, you start to get arthritis, then you get hammer toes with the other one. So you know, the type of bunion that's performed is dependent on the angles and measurements in which stage they're in. Once you get to the arthritis, it pretty much gets rid of everything because you're in a salvage procedure instead of a repair procedure. Does that answer your question?
Yes, it does.
Okay. We're going to talk about hammer toes because that's related. If you look at this toe, there is a tendon on the top of the foot pulling the toe up, and a tendon on the bottom of the foot pulling the toe down, and basically a muscle imbalance again develops where the one on the top overpowers the one on the bottom and causes the toe to contract like this. Here's a diagram of how this occurs. And when you get that redness, obviously the thicker the hammer toe gets, the more it's not going to fit into a shoe. The symptoms are redness and pain, but they develop just like a bunion develops over time, whereas a muscle imbalance occurs. Hammer toes, as I said, are a contracture or bending of the toe at the first joint of the digit. The toe actually pulls up, and when it pulls up, it won't fit into shoes. Now, any toe can be involved, but most commonly it's the second through the fifth, the second being the most common. I think it's more common in women, in my opinion, because they wear shoes that don't accommodate toes as well. Far be it from me to ever rip any shoes that any women wear. But women are going to wear tighter, therefore they're going to notice hammer toes more. Corns develop on top of the joint when there's friction. And when the corn develops, it's basically your skin's response to too much friction. In my way of explaining it, the skin gets trapped between the shoe and the bone, and it thickens up as a way of protecting it. But when you get a corn, it's not protection. It actually puts on more pressure onto the bone, which again puts more pressure on the nerves and the blood vessels. That's where you get the redness from. And later stage hammer toes will not bend at all. They're called rigid hammer toes. And once they're rigid, that's strictly a bony problem. We talk about conservative versus surgical treatment options, padding and taping, medications. Orthotics are used more in a preventative type thing. I've had a lot of people that are mostly geriatrics that come in and will say, look, we need to cut a hole in your shoe, or we need to get you in a pair of sandals, because if those toes rub, they will turn into an ulcer, which is easily infection, and I see a ton of infected corns. I shy away from using any type of over-the-counter corn remover. Most of those corn removers have acid in them, and the acid eats away at the skin. The acid doesn't know the difference between the good skin and the bad skin, and I see more infections, especially in diabetics, that use the over-the-counter corn remover, so to speak. So I'm a big proponent of not using those. Surgical options. Our surgery is basically a way to fix it. Less severe hammer toes, which are caused by the muscle imbalance, the tendon release, is a simple way to do that, slight bone remodeling. For the more severe or rigid hammer toes, again, those are the hammer toes that won't bend at all. We remove a portion of the bone or fuse the joint where it's contracted like that. Now that we're away from the 70s, 80s, and even 90s, these types of procedures are fairly routine and very simple, done on an outpatient basis under really local anesthetic, and the recovery rate is anywhere from 2 to 4 weeks, depending on the toe, and very, very simple. Most of my patients don't even take pain for this type of thing. Really, really easy. Let's see here. I want to talk a little bit about nail problems. That's what's kind of in the news these days. Onychomycosis is the term for fungus toenails. Onychocryptosis is the term for ingrown toenails. When I talk about onychomycosis, you can see the way these nails are yellow. There is a fungus infection, and this happens to be one with a corn right here, which is also a hammer toe. But when you get a fungus infection, a fungus is in the air. It's all around us like bacteria. It's just pretty much everywhere. And the fungus loves to live in a dark, warm, moist environment. Really not a better place on your body than when you're wearing shoes. So if we can use an antifungal powder down in the socks or shoes, that gets rid of the moisture and the heat buildup. But once you get a fungus infection, it's like anything else. It's really, really got to be treated. I treat fungus primarily by treating the symptom. If the fungus is already in the root of the toenail, it's going to grow out with the fungus already in it. If it's in the end of the toenail or just beginning, you can use a topical medication, and we'll talk about some of the topical medications. This is a really severe case of fungus. Nails look really gross, and most people see this on television or know somebody who has this. This person not only has a fungus of the toenails, onychomycosis, but they also have an athlete's foot infection, which is why these are all pink. And these can get very, very serious because if circulation is impaired, they block circulation to the toes, and people can even lose a digit with a fungus infection. Treatment options we talked about real briefly. Topical medications will work if they're used properly. They do take a long time to work, but it depends a little bit on how bad the fungus infection is. Oral medications, are very, again, popular these days because you see all the advertisements on television. I use Lamisil. It's certainly not a guarantee, but I have about an 80% success rate using that. It has to be used on the right patient. We do run some lab work on that. Lamisil is metabolized in the liver. It's not toxic to the liver. We run liver function studies so that we're able to tell our patients that they can metabolize the medications. There are a few other little side effects as there are with any other medications. I don't own any stock in Lamisil or anything like that, but it seems to be the one for me that works the most efficacious. And then surgical intervention is done basically when the fungus is so bad or the patient can't take oral medication. If they start getting pressure on the digits where the circulation is impaired or they're having some sort of problem where the fungus is actually making it difficult for them to wear shoes, or in a diabetic, surgical intervention to remove a toenail is a very, very simple in-the-office procedure. Removing a toenail, there's no pain, there's no stitches, there's no keeping it dry. It's a really good procedure. I know people say, well, how disgusting would it be not to have a toenail, but sometimes it's more disgusting to have the toenail. Ingrown toenails or onychocryptosis. Here's an example of a couple of infected ingrown toenails. The one on the left, on the side of the nail here, you can see where somebody tried to cut that back. Usually people do their own little bathroom surgery and infect these much more than they are when they come in, but the root of the nail back here is what determines how the nail grows. You're not going to cause an ingrown toenail by trimming it wrong unless, of course, you get into the skin, which the skin puffs up around the edge, and when it puffs up around the edge, you now have an infected ingrown toenail. This is a toenail not from fungus but from trauma. This person hit their toenail, dropped something on their toenail. That's like a little blood clot under the toenail, which is called the subungual hematoma. And then because that thickened up, it caused the nail to get ingrown here on the edges. There is conservative care and permanent surgical correction for these. Conservative care basically consists of trimming out the nail and keeping the area calmed down. There's very simple ways to surgically correct these. You don't have to have your toenail removed. Cosmetically, a lot of these come out really good. We do a lot of these on young people, kids that get recurrent ingrown toenails. Ingrown toenails are not the same as infected ingrown toenails, though. Ingrown toenails can occur, and you can trim your nails properly, straight across, all that kind of thing, and not have a problem. It's just when people start going down the sides and down the edges and they get them infected, that's when they get to be an infected ingrown toenail. Recurrent infected ingrown toenails require surgical procedure to permanently fix those. One of the things we're going to talk about here is heel pain. Heel pain is so common. Every single day people come into my office with heel pain. Heel pain is caused from a lot of different things. The most common is plantar fasciitis. The drawing on the bottom right there shows the ligament, and that's what it is, a ligament, not a tendon. It inserts on the bottom of the heel in one or two areas and inserts into the ball of the foot in multiple areas. The plantar fascia basically makes up the bottom triangle of the foot. So when the foot pressure goes down in this direction, a downward motion, these areas here are put under tension or strain. Plantar fasciitis is the tearing of a ligament off the bottom of the heel. When these pull, they can result in a heel spur, but a heel spur is essentially bone that's laid down where the tension of the plantar fascia is. Generally, the plantar fasciitis pain is from the tearing, it's a literal tearing of the ligament off of the heel. I've seen on X-rays heel spurs that stick out 3/4 of an inch off the bottom of the foot, and that's basically growing from here. The heel spur does not hurt. It's the ligament tearing away from the bone that causes the pain. And as this said, 90% of these resolve with conservative treatment. The conservative treatment essentially is treating where the ligament pulls away from the bone. Now, just to be clear, all heel pain is not plantar fasciitis. Calcaneal apophysitis is heel pain, or what they used to call Sever's disease. A lot of kids play soccer. A lot of kids play sports. That is different than regular heel pain. It has nothing to do with plantar fasciitis. Arthritis can cause heel pain. Stress fractures are very common. I can't tell you the number of people. Matter of fact, I had a lady last week who came in who was diagnosed with plantar fasciitis by her regular doctor, and she wasn't getting any better on his treatments. And so we looked at her X-ray. She had a classic stress fracture, which was being treated as plantar fasciitis. And I've done the same thing where I will have people come in the office. I treat them for plantar fascia, and they don't get any better. We got to look at other things, and very commonly it's stress fractures. Achilles tendonitis, bone cysts, pinched nerves. Carpal tunnel often occurs in the wrist and the hand. There is another condition called tarsal tunnel, which mimics plantar fasciitis. Actually very easy to differentiate that, but that's called tarsal tunnel. And then also low back or disc problems can cause heel pain as well. Moving along, plantar fasciitis, I want to talk a little bit about that. This x-ray is showing a heel spur on the bottom or plantar surface of the foot. This also shows a heel spur on the back of the foot. This is a calcification back here where the Achilles tendon inserts. One of the ways our body compensates for too much plantar fascia pull is to increase the pull of the Achilles tendon. A lot of people will come in with both pains, or we'll treat the plantar fasciitis and they'll come in and say, well, now the back of my heel's hurting. That's actually easier to treat because that's a tendon, not a ligament. Ligaments don't heal like tendons do. Ligaments tear. Tendons can stretch. Ligaments don't. But pain, classic symptoms is pain in the bottom, or what we call the medial aspect of the bottom of the heel. That pain when you get out of bed in the morning and you can't take that first step. That's a classic plantar fasciitis pain when you're walking for the first 2 or 3 minutes and then it kind of goes down a little bit. Really not with any particular type of foot, but we see this, I would say, in equally in high arch foot and low arch feet. Nerve conduction studies, which this says here, is basically to determine if that is a nerve problem or the plantar fasciitis. We don't use MRIs for this because we know pretty much what the diagnosis is going to be depending on how people relate to the treatment.
Do high heels produce plantar fasciitis?
Go ahead, Dave.
Wearing high heels, can that make produce plantar fasciitis, or could it worsen it?
Actually, it's funny. High heels will take away the symptoms of plantar fasciitis because when your foot is in a high heel, you're in a supinated position as opposed to a pronated position. The supinated position of the foot takes stress off of the plantar fascia. Now, the problem with high heels is that people don't wear high heels all the time. So when the mechanism is that when you're in the high heel, the pressure is taken off of the heel, but when you get out of the high heel around the house, doing everyday activities, that's what causes the strain on the plantar fascia. So when you go from one type of heel to another or one type of shoe to another, people always develop, sometimes develop the plantar fasciitis because they switch from a high heel to a low heel. Also, too, now the Achilles tendon, where it inserts, is really aggravated by high heels because the back of the heel, and in this diagram on the bottom, that little bump that's there, we call that a pump bump. As this foot gets, the architecture of the foot changes in a high heel so that this actual bump actually becomes more prominent. So people that wear high heels are more likely to get the back of the pain or the Achilles bursitis pain. Then they get out of the heel into a regular shoe, and then that's where the plantar fasciitis kicks in. So the mechanics are what cause the pain, and that's how we treat the cause of the pain, by changing the mechanics. I don't use a lot of anti-inflammatories in my office because I really don't need to, but you've basically got to get the mechanics of the foot in such a way that they're taking strain off of the plantar fascia. And that's the key to treating this conservatively, is to stop the cause of the problem. The cause is something that causes too much strain on the plantar fascia. If you change the cause or change the pull of the ligament, the pain will go away, it will heal, and then you can use a way to get like orthotics, to get the stress off of it. Stretching is okay. Generally, stretching is not what I recommend for plantar fasciitis. You can take the pressure off of the initial, off of the ligament initially, but you're not going to do it long term. Plantar fasciitis is an injury. Think of it as an injury. Think of it as a torn ligament off the bottom of the heel. You don't want to stretch it and put more stress on something that's already under too much stress. Now, shoe modifications, avoid walking barefoot. Obviously, those are common things. Icing and resting. You know, icing, when something's inflamed or it is becoming inflamed, icing it is really good to keep the the inflammation to a minimum. But you just can't ice your foot all the time. Arch supports, I mentioned before, I'm a big believer in custom orthotics rather than over-the-counter type orthotics. Anti-inflammatory medication is used sometimes. Steroid injections are very popular. The problem with the steroid injection, in my opinion, is that when you use a steroid introduced into an area, you're stopping the symptoms. You're not stopping the problem. Someone gets a shot and they feel great while the medication's in there, but when the medication is absorbed into the tissues, you still have the problem because the mechanics of the foot haven't changed. So I'll use a steroid injection as sort of a booster. If someone that we've been treating with taping or strapping comes in and their pain is almost gone but not quite up to the level where it needs to be, we use an injection to boost it. But I have people come to my office who've had 10, 12, 15 injections and they're not any better. And actually a steroid injection can weaken the tissue and actually make the problem worse.
Right.
Not a big proponent of surgery, just because I don't think it's all it's cracked up to be. I'm going to talk real briefly about a few things. Extracorporeal shockwave therapy is kind of new. It's minimally invasive. I've had about 50 to 60% relief with that. What they're basically doing is hitting the insertion of the plantar fascia in the bottom of the heel with shockwave, creating an overproduction of inflammatory responses. It is somewhat painful, and you are limited as far as weight bearing for 4 to 6 weeks after surgery. We used to do, I mean, I've been in practice 21, coming up on 22 years. We used to do an open procedure where we'd basically go in and take off the heel spur or release the plantar fascia off of the heel. Really, patients were 50-50, so to me that's not good enough odds on treating someone. We do have a procedure now called an endoscopic plantar fasciotomy. That is a procedure which I actually was someone on the forefront of talking about this. It was invented by a friend of mine in Houston. I was one of the first podiatrists trained in Oklahoma on this, and it's a really neat surgery, but again, it's a very, very last resort. When 95 to 97% of your patients get well without surgery, we rarely even get into talking about this. I've had people come in from out of state to have this surgery done. It has a fairly low complication rate, but essentially what it is you're using a TV camera to go in and look at the insertion of the plantar fascia. You make about 1/8 of an inch incision on the side of the foot and insert a camera, and you can see the plantar fascia, and you release just a small portion of it so that it takes away the pull or the tearing. Now, it is essential that patients are in custom orthotics before and after this surgery, and remarkably, a lot of patients get into an orthotic and don't have pain. Therefore, they don't need the surgery. But I would not do this on someone that did not have orthotics, because usually it's not necessary. The patients are up the same day, certainly no athletic activity for about a month, but it is a kind of a remarkable thing because you can actually, we use an endoscope, and you're inserting the endoscope into the foot where you can actually see the insertion of the plantar fascia, and you're releasing just a minimal amount of it. Some physicians do this through what they call minimal incision surgery. I'm not much for sticking a knife blindly into the bottom of a foot. That's just my personal opinion. So I prefer to see exactly where I'm going to be cutting. That's why we use the endoscopic plantar fasciotomy, or what we call an EPF.
Why does this? Why does the fasciitis improve during the day? You said the first time when the person steps up on the floor in the morning, he has the pain, but as the day goes on, it improves. Why does that happen?
Well, my thought on that, and I'm not sure anyone really knows, but my thought on that is that throughout the day, someone is on their feet, the plantar fascia is under constant strain, and not stretch, but strain. The insertion of the plantar fascia, where it's minimally attached, is under a lot of tension, a lot of pain. People are in a lot of pain because that is constantly tearing. So you go home at the end of the day, you get off your feet, you go to bed. That plantar fascia insertion starts to repair itself. It starts to bring an inflammatory response, which is trying to repair the torn tissue. Well, what do we do when we get up in the morning? First thing we do is get up, step down on that foot, and re-pull the plantar fascia. So, in my opinion, that initial pain comes from everything trying to repair itself overnight to stepping down and just ripping everything that you just tried to repair the night before. So that initial pain occurs from tearing those initial fibers, and then as you're on the foot a little bit for a few minutes, it starts to sort of equal out. The pain doesn't go away, but it's not nearly as bad as that initial step down out of bed. And I have had plantar fasciitis, so I know exactly what that initial pain feels like. I do wear orthotics in my shoes, but remember this, orthotics are not used to treat plantar fasciitis. Orthotics are used to keep plantar fasciitis from coming back again. The treatment, the taping, the physical therapy, the methods that we treat it are used to get it well, and then an orthotic is used to keep it that way. A lot of doctors just, hey, here's, you go in with heel pain, here's some, $500 orthotics, and, they're not any better. Well, if you don't heal the injury, then it's not going to be better. You got to heal it and then use an orthotic to keep it that way. Make sense?
Makes sense. Someone asked the question: how do comfort shoes work? The rocker soles?
Comfort shoes. Is that a specific type of shoe?
Comfort Plus. shoes?
You know, there are a lot of shoes out on the market these days which are designed for a particular type problem. There's the rocker bottom shoes. You know, this is just my opinion. The gait cycle is fairly complicated. From the minute your heel hits the ground to when your midfoot rotates over to when you have heel lift and then push off or toe off portion of gait, as well as during the swing phase of gait, your hips, knees, and ankles and feet are designed to do something specific. We know what the normal function of the foot is, so I'm not, and this is just me again, I'm not a big proponent of specialized shoes to treat foot problems. I'd rather treat the foot, and then like let's say we make an orthotic. That orthotic can go in any kind of shoe rather than having a specific type of shoe, because that turns out to be the only kind of shoe you can wear. You know, there are a lot of insoles in shoes that accommodate the way a foot operates. There are, believe me, there's the places here in town that sell shoes that are designed to make your legs look better and designed to make your calves look better. I mean, that's all fine, but you're messing with the normal angle and base of gait and the normal function of gait. I don't have anything against any of these shoes. There are a lot of shoes that are being sold through podiatrist's office now, and my belief is, hey, if you wear a shoe and it makes your feet feel good and you love it, then wear it. You know, it's one of those things like wearing Birkenstock shoes. They're real popular. Everybody loves them. Hey, if you like them, great. Now, if you have that kind of a foot that is not conducive to wearing that kind of a shoe, then you're only doing yourself some damage. You know, we used to make molded shoes for diabetics, and we still do in some cases, because diabetics can only wear a certain type of shoe, or else they end up with foot deformities, and the foot deformities that they have will be aggravated by, say, a regular tennis shoe or a regular dress shoe. So, you know, in my opinion, when you start getting into certain shoes that are supposed to do things for, you know, certain types of feet, it gets a little bit complicated, and not everybody's feet are designed for the same kind of shoe. I use the old analogy that someone comes in and says, well, this shoe caused my corns. Well, okay, that may be true on that particular person, but it's not true for everybody, because otherwise that shoe would cause a corn on every foot. So we need to be, at least what I try to do is be very specific on the type of foot that I'm dealing with, and if I recommend shoes, it's for a particular activity or a particular, and I'm not against high-heeled shoes, but there are some shoes that are better than others. Just because you spend a lot of money on a shoe doesn't make it the best kind of shoe.
And you just answered another question.
Go ahead.
You just answered the question about the orthotics. So you can use the same orthotics for different kinds of shoes, in other words.
Yeah, that's what I plan. I mean, there are specific orthotics for specific things. Like running, for instance, we do make a specific type of. I mean, if I have an avid runner who's an athlete, who's a marathoner, who runs more than, say, the average person, I'll make them a running orthotic. I have a sports orthotic in my shoes that I use, which is real. It doesn't work as well as my everyday shoes, which I have just sort of an everyday type of an orthotic. So we do make specific orthotics. Not that you need one for every different kind of activity, but start-stop sports like racquetball, basketball, things like that, a specific type of transverse plane correction or limitation would be better than, say, a walking type of an orthotic or a sports orthotic. And we do make some orthotics for high-heeled shoes, things like that.
Okay.
Okay. Let's move on a little bit. Some of these next slides are going to be a little bit graphic. I wanted to include some of these because I do take care of a lot of diabetics. I can't stress enough the way people need to take care of their feet if they're a diabetic. Being diabetes does not give you a death sentence. A lot of people live long, healthy, happy lives with diabetes, but you've got to take care of your feet. Everything from common hygiene type things and moisturization to taking care of problems before they get out of hand. These are two diagrams of ulcerations that have occurred. These are blisters that turned into calluses, that turned into ulcerations. This is an example of what we call a Charcot type foot. That type of foot is where the anatomy inside the foot due to neuropathy gets messed up, and there are bony prominences where there really aren't supposed to be any bony prominences, and this is an indication where a bone has literally tried to come through the arch and develop into an ulceration. Now, having said that, we talked about orthotics. If someone gets a recurrent callus on, say, the first metatarsal or the ball of their foot, if that's their prominence and they walk and they can't feel the bottom of their feet, they're not going to know they're developing a callus, which is eventually going to turn to an ulcer. So we sometimes will make what we call an accommodative orthotic, which is, again, a mold of the foot, but we accommodate for that pressure point so that when they walk, they don't have to worry about that area being a pressure point, which is going to turn into an ulceration. And we use orthotics on a preventative basis. And again, these are custom orthotics, but we use it to prevent the diabetic from developing an ulcer, which can turn into an amputation. And you know, we all say once you lose a toe, you're going to lose your foot, you're going to lose your leg, and you know, most of that is preventable. I always tell diabetics, please pay close attention to wounds, blisters, calluses, corns. If you get if you're a diabetic, and even if your blood sugar is under excellent control, and I think the whole basis of this is assuming the blood sugar is under good control, because the two senses, the two portions of the body that are most involved with diabetes are the vascular portion and the neurological portion. Neurological meaning diabetic neuropathy. I think neuropathy personally is too much of an overused term these days. In my instance, for the purpose of this lecture, it means lack of feeling in the feet, whereas someone would step on a piece of glass, not know that they did because they can't feel their foot, or get a callus that bleeds. They don't know it's bleeding until they see the blood in their sock, and then they develop an infection, and sometimes by then it's too late. But if you're a diabetic, no reason for you to be carving on your own foot, no reason for you to be trimming corns and calluses. And I mean, you can trim your own nails, but if you notice a red spot or some skin thing that you don't know why it's there, call your podiatrist, because I have patients weekly who come into me and say, look, I saw this thing, what is it? And I'll say, look, that's nothing, you need to moisturize some more, that's it. But I do have patients who come in and say, look, I've got this corn and it's turning yellow or red, and you know, we save their foot. I mean, we save their foot, we save their leg, simply because we train our patients. And most of these days with diabetic educators and internal medicine doctors, you know, we're telling people what to look for, how to evaluate it themselves, when to go get help. But most of it's just common sense. Just don't be a bathroom surgeon. This is an example of a callus that was untreated, and a callus under the second toe where there was a hammer toe. This callus was untreated, and you can see this big, thick, callousy-looking thing. This person couldn't feel it. They develop an ulceration with the hole all the way down to the bone. The bone becomes infected, and then you've got a disaster on your hands. Now, having said that, callus turn into ulcerations. We treat a lot of patients with surgery where we can actually cut that out, get rid of the bad tissue, and you can see in the progression of these pictures, this being the same foot, how we can actually heal that up. And obviously this is a person who has neuropathy, decent circulation, obviously enough to heal, but this sort of thing is preventable. So not to gross anybody out or anything, but you know, in my office I don't take any chance if someone has an ulceration, someone has something serious. We do vascular evaluations. You know, this gets back to what Dave was talking about, of being a complete medical team, about, you know, the whole body approach to to medicine. And I'm the foot guy, so if I see something like this come into my office, we go from getting a vascular workup to their internal medicine specialist, their cardiologist. We do a neurological workup on them. We all work together as a team to keep the foot on the right from looking like the foot on the left. So enough of those fun pictures. Sorry about that. Dave made me put those in there, so I didn't mean to. But
if it bleeds, it leads.
What's that?
If it bleeds, it leads.
Yes, that's true. And I don't think a podiatrist can really talk about just you know, just foot stuff without actually people understanding what can happen to diabetics. It doesn't mean it's going to happen, but it means you really got to take care of your feet, and that means everything from moisturizing to powder to examining your feet every day. You know, I've been in these little pharmacies now. They make these mirrors where you can look at the bottom of your feet now, which is just great because a lot of people can't see the bottom of the feet. They haven't seen it in years. I do want to talk a little bit about trauma, because I handle a fair amount of trauma. When I'm talking trauma, I mean sprains and strains, fractures, lacerations, those types of things. There's a big misnomer in feet where someone, you know, everybody's walked through the dark and hit their foot on a chair or the edge of the bed, and wow, they say a few expletives and they look down and their toe is sideways or it becomes red and swollen. Obviously, one of the most important things you can do is put ice on it, elevate it, get off of it. But people break their toes, and this misnomer about nothing you can do for a broken toe. Well, speaking as a foot guy, there's a lot you can do for a broken toe. There's 3 bones in toes 2 through 5, and 2 in the first toe. And when those bones break, they are just like real bones, like your leg bone or your hip bone. If they break, and that involves the joint, that will become an arthritic condition. You think the toe is fat now. When it gets to be arthritic, not only will it not move, but it hurts in all your shoes. So all toes are broken, but it means that when you have trauma, you got to get something evaluated. You know, if you hurt your foot, you hurt all over. When you're off your feet, you're depressed, you're down, you can't do what you want to do, and we treat these kinds of things every day. If I can get my slides to keep going here. This is just an example of a broken toe. When I talk about the trauma for a toe, this is an example of somebody that slammed their toe in a piece of furniture and they broke off a chunk of their bone here. This is the joint. If this is untreated, this will eat away at the cartilage on this joint, and sooner or later that will not go back together. Now, this is an intra-articular fracture, meaning involving the joint, so the chances of a non-arthritic situation are very low anyway, but this is an example of what we do. You can have a screw put in, a pin put in. You do not want to ignore things like that. And I always meet someone who comes in, oh, I broke my toe and I got over it, I'm fine. But years later down the road, when you develop a hammer toe or something like that, it doesn't mean everybody needs surgery, but when these things get out of alignment, when all these digits get out of alignment from trauma, you usually don't end up with as good a result as you would have if you got the thing treated right away. This is an example of a forefoot injury. On the left, you can see where this looks like a bubble type here. These are fractures of the metatarsals. This is really someone who came in a car wreck and jammed their foot down on the floorboard, and they broke all the metatarsals. These are screws that have been put in there, obviously, to fixate those fractures. I can't tell you the number of people who have come in from having an injury of something else, then the foot was overlooked in the emergency room. People fall off a roof, fall off a ladder, they land on their heels. Obviously, the first thing you check is the back, but people will fracture their feet or break their feet, and they go to the emergency room. They never even take an X-ray of the feet. So, I see this thing a lot.
Good point.
Listen, as far as me treating feet, I put a cute little picture here of feet, a little foot, because, it's never too early to start looking at your feet. And, those little feet of little kids, I'm a big proponent of the right shoe gear for kids and taking care of your feet from the minute you're there up until you get to be an old fogey.
Good point.
Questions, Dave?
Oh, okay, great. Oh, man, this has been a lot of information in a short time. Thanks a lot, Mark. Sherry, I have a couple of questions. Sherry, did you collect any questions during the talk?
Just the same few that you're probably seeing.
Well, I'm not seeing any at all. I'm not connected, but let me ask a few, and then you can ask a few yourself.
Okay.
Okay. Someone asked, how do you fit people with feet of two different sizes for orthotics?
How do I fit them for orthotics?
Yeah, if someone has two different sizes, do you take each foot separately and fit them?
As I said, orthotics are custom made. We take an actual mold of the foot, and then whatever the position that we want the foot to be in, is, for whatever we're trying to treat. But yeah, we always take a mold of both feet. We never ever take one of one unless they only have one foot. But orthotics are designed to treat, whatever the foot problem is, but if you only put one in, they're either going to be lopsided or end up with a problem on the other foot. But yeah, we always do that. And then we fit them in the shoes, and I always tell people if you're going to get new shoes, don't get them until after you get your orthotics. They don't take up much room in the shoe. There's a few shoe brands out there that actually make shoes that accommodate an orthotic well, and then most shoes have a liner that can be removed depending on, again, what the activity that you want to wear the shoe for. So when we treat people using orthotics, we make an orthotic that's appropriate, whether it's a very thin graphite device or a thicker accommodative device. We make it that's appropriate for the foot and for the shoe. But they're custom made.
Great. Okay, flat feet. How do you deal with people with flat feet?
Well, flat-footedness is more of an observational thing now. There's really not a diagnosis which includes flat feet. Generally, we break people down into types of feet. Say, for generic purposes, the flat-footed is one type of foot. That type of foot is more prone to having certain foot problems. Let's say a bunion or a hammer toe would be much more common on someone with a flat foot than it would be, say, a rigid foot. Now, if there's pain from the flat feet, then we have to determine what's causing that pain. Shin splints are very common with flat feet. General foot fatigue is very common with people with flat feet, because if you think about it, the foot becomes flat when it's in its maximally pronated state. That's when it's in its massive shock-absorbing state. So the foot rotates over a lot farther than it needs to. Depending on the symptoms of the person with the flat foot, that's how we treat that with an orthotic based on And that's the conservative approach. We treat that is based on what we're trying to do with the orthotic. Surgery can be done to correct flat feet. My personal opinion, I'm not a big proponent of surgery for flat feet unless it's a pediatric patient or unless there's going to be some problems down the line. But there has to be a cause. Once you identify the cause of the flat-footedness, then you work on treating the symptoms and then the underlying cause.
What level of relief can be expected from orthotics for flat feet? I guess that depends on the cause, right?
Well, it depends on the cause and what the symptom is. Are they having pain in their foot? Are they having pain in the lower leg? That's again getting back to the specifics of making an orthotic. I mean, the whole goal of using an orthotic is to permanently 100% eliminate the foot pain. Orthotics, they're not magic. They're not, they're made to do a certain thing. So if someone comes in with flat feet but is having ankle pain, we make an orthotic to control that. If the flat-footedness is causing bunions or forefoot pain or ball of the foot pain, then we make an orthotic that treats that. I mean, flat-footed people, and believe me, you're talking to one, have a whole wide range of things that can go wrong depending on the architecture of the foot. So flat-footedness is somewhat of a generic term, but you got to identify the symptoms.
Someone typed in he's flat-footed and he has knee pain and some back pain.
Well, then an orthotic, similar to what my friend Dean had, we used an orthotic in that instance to limit the amount of pronation that the foot had. And again, we don't just make orthotics for people. I'll go through an x-ray evaluation, possibly a gait evaluation. We need to make sure that if the back and the knee pain is coming from the foot. Now, one way to determine that is we put a taping on the foot that mimics an orthotic. Let's say if an orthotic limited the range of motion, say 0 being none and 10 being a lot, we'll tape someone up at about a 3 or 4, and we'll see if we decrease the symptoms by mimicking what an orthotic does. Now, if the symptoms decrease, then we may strap them or tape them again in a more rigid type of fashion that would more mimic what an orthotic would do. And if the symptoms start subsiding, we say, okay, then we know that an orthotic is going to help you with those symptoms. If not, it may not be the foot. It may be the knee, it may be the hip, it may be something else. But that's how we can tell if it's a foot problem or not.
Got it. Hey, Sherry's going to ask a couple of questions now, but could you put it on the slide with your address, the information on?
Yeah, as long as no one calls me.
You can put David's number up.
I wouldn't put it up there if I didn't want you to call me.
Okay. I had a stress fracture in my third metatarsal on my right foot. It has healed, but I still can't walk the distances that I was used to, 3 or 4 miles daily. When can I expect to be able to walk more?
Well, that is a very good question, and here's the answer. First of all, was it healed through treatment, or was it just healed on its own? Because stress fractures healed on their own take a lot longer to get over, and a stress fracture that's healed with the proper treatment is usually about 6 weeks, maybe 8 weeks at the most, depending on circulation and depending on the rest of the foot.
Okay. If something healed improperly, what would need to be done?
You mean, are we talking about the stress fracture or something in general?
The stress fracture.
Well, it depends. It's funny, and I don't keep meaning to go back to orthotics, but I'll use the stress fracture as an example. Stress fractures, especially the second and third metatarsals, generally fracture at the neck of the bone or at the base of the bone. And unfortunately, because it's a weight-bearing bone, when you walk on a stress fracture, it actually elevates the bone and it heals in an elevated position. So one of the reasons that people that have a stress fracture that is not treated properly have long-term disability type problems are because that bone is now elevated, basically putting more stress on the other bones. It's very common to have one stress fracture and then someone have a stress fracture in the bone right next to that because that bone is now absorbing all of the stress. So what can be done about it is dependent on what the symptoms are. If it's pain, then we need to evaluate whether the pain is coming from the original fracture or from the one next to it or from a cause from malalignment. I see a few people where I would recommend surgery and going and having the bone put back where it should be, but frankly, nature does a better job of healing than we as surgeons do. If a bone is completely dislocated or completely out of whack on an x-ray, then we have to go put it back surgically. Stress fractures are generally not that way. So the symptoms that occur from improperly treating stress fractures can be anything from tendonitis to bursitis in the ball of the foot to another stress fracture. It's just hard to say without actually seeing an x-ray and evaluating the foot function.
Okay, wow. We had actually quite a few questions come in, probably because everybody has feet.
I know, that's amazing, isn't it?
Okay.
I'll answer the shorter answers if you'd like.
Okay, no, this is fine. When numbness in the feet has not been shown to be diabetes or any other particular disease, will orthotics help? This person sees a chiropractic weekly. They did fall out of a tree a few years ago. They can't seem to detect any cause, but they're having some numbness in the feet. So I guess the question is, with numbness in the feet, with that scenario, will orthotics help?
Well, again, it gets back to the cause of the numbness. One of the ways I would see if orthotics would help is to tape the foot. It's called the Lodi strapping, and tape the foot in a strapping, again, that mimics what an orthotic would do. If the numbness is due to a foot pathology or a foot problem, then this will, and they need orthotics, then that would help. If you fell out of a tree, you probably have something going on with the back, and the first thing I would do is either get an MRI or see a neurologist to have a nerve study done and rule that out. If someone comes in and says, okay, I've had this study done and they've got perfect function and all that, maybe it's a pinched nerve, but it sounds to me like that may be coming from an injury.
Okay. What is the problem when a little toe is half on top of the next toe, and will toe separators help?
Well, it depends on the age of the patient. If it's an adult and that is already established in that position, there's a contracture of the tendon. The one tendon that moves the toe in that direction is in a fully contracted state, causing what's called over-rotation of the fifth toe, an overlapping fifth toe. The capsule or the ligaments inside have also adapted to that position. So using a toe separator may help somewhat cosmetically, but it's not going to change the toe. That's usually a simple surgical thing to make a release there, where you drop the toe back down to a regular anatomical position. And again, I'm dealing with somewhat abstracts and generalities as if this is an adult, but it's a fairly simple thing to take care of.
Okay. Do you have any advice for a nurse who spends long hours on their feet and is getting some heel pain?
Well, first thing, obviously, that I'm going to talk about is shoes there. You've got to wear decent shoes. You've got to wear shoes with very good shock absorption. As an example, I'd say a New Balance walking type shoe. Now, most nurses' shoes are made with a good heel counter. You need an insole or a midsole that's very shock absorbing. If you get a lot of heel pain, it's either a plantar fasciitis type thing, or it's from the shock of the bursa underneath the heel. The bursa is basically a pillow on the bottom of the heel, and standing long hours or constant pounding causes that bursa to get inflamed. So the more shock absorbing material you can have in your shoe, say a Spenco insole, not an orthotic, but a Spenco is the name of a brand. S-P-E-N-C-O is the name of a brand of an insole that is designed to give a little bit more shock absorption. That would help. But be sure you're in good shoes that are not worn out. I mean, really good lace-up type walking shoes that hold your foot in a more rigid capacity.
Good. David?
Okay, got it. Sorry, I was on mute again. All right, here's my question. If my big toe was bent extremely bent backwards, and I still have pain after 2 months, could there have been tendon or ligament damage?
Oh, absolutely. Yeah, I mean, absolutely. If it was given enough time to heal, then and it went through the proper stages of healing, and you're still having pain, there certainly could be some permanent damage. I mean, it's obviously not normal for your big toe to bend that far back, depending on where the pain is. But you could certainly tear something on the bottom. That's the plantar plate, it's called, on the bottom of the ball of the foot. Is well, when that's torn, that's a long residual. Sometimes people don't even get over that for a long time, months.
Okay. I'll ask another question. What's the problem with turned-in feet?
I'm assuming we're talking about feet where, say, if you're looking down at your feet, your big toes are kind of pointing into each other. The mechanics of that foot, and that would be sort of like a club foot would be a severe case of that, or lesser of that we would call a metaductus type foot, which is a C-shaped foot where looking down at the foot actually creates a C shape. I mean, that would, depending on the age of the person, that would require X-ray evaluation and to find out, exactly what is causing that. We see that sometimes on cerebral palsy patients where the contractures of the for a generic terms, the muscles and tendons on the inside of the foot are contracting more and the balance is off, so it makes the feet turn in a little bit. Depending on the age of the patient, that's something that can be corrected usually conservatively or with the use of an orthotic.
Okay, thank you. Do you often see patients with sudden severe pain on the top of the foot with no obvious cause, and what treatments, causes would you consider?
The only thing that comes to mind on something like that, the nerves are very superficial on the top of the foot. I mean, the top of the foot has basically skin, a few blood vessels, and the nerves are very superficial. Matter of fact, you can even see them when you look through the skin, and then bone. So the most common thing I hear with that is someone that wore a shoe that was too tight. And I don't mean it was too tight for them not to notice, but it was tight throughout the day and the foot swelled throughout the day, and the shoes either weren't loosened or maybe laced up a little too tight, a fold over of a sock, something like that, would cause a sharp pain in the foot. If there's nothing that dermatologically can be seen, we evaluate that by knowing the anatomy. And then if it's a superficial nerve that's becoming irritated, which is the most likely cause, if there's no swelling, no redness, nothing like that, if it were me and I was having the first thing I do is apply some ice to it to get the inflammation calmed down, because if you're having pain, it's obviously something that's inflamed. And then I would do a shoe evaluation of yourself to make sure that, you loosen up your shoes throughout the day, something that's really not putting a lot of pressure on that area.
Okay. My doctor says I have long horn toes. Can you explain what that is and how to fix it?
Long horn toes. I don't know what that means. There's toenails that are horned, but it'd have to be a better description of what it looks like.
Okay. Okay, this person 5 years ago had what they're calling a soft tissue injury. They ran their foot into a chair. No broken bones. It was really painful at first, but now 5 years later they're having a lot of numbness, cramping. What can be done? Exercise it or what?
Well, you got to figure out what the problem was. I mean, if obviously to me that stems back to the original injury, and if they're still having problems, there was some sort of permanent damage. Again, in the end of the foot, especially in between the toes, the nerves are very exposed there. And if someone slammed their foot into a chair or some furniture, there may be some scar tissue that's inflaming one of the nerves that's there. It may be the foot function. There may not have been bone injury, but there's a lot of stuff to go wrong down there. And if something's injured and it's been that long, then I think it needs to be reevaluated from the stance of, again, this is what I want to do and this is what I can't do because my foot hurts, and then we evaluate not only by the history but by the anatomy in the area and find out what it is.
Okay. This person is saying, thank you so much, Mark. Your info has confirmed for me that I am suffering plantar fasciitis after returning to on-the-feet work 6 weeks ago. Now I know what has to be done. You're brilliant.
Well, that's great. I'll tell you something. Look a little bit of something. I have, every day I have patients that come in that bring me stacks of paper about plantar fasciitis, what they've read on the internet, what they've heard. I laugh when I hear about these professional athletes, especially the basketball players, who miss a game because of plantar fasciitis or who take time off because of plantar fasciitis. Very easily treated, not always cured. I don't want to sound like it's the simplest thing in the world, but stay away from some of the stuff you see on the internet, because these days, and as you all that are listening probably know, not everything you read on the internet is true. And when it comes to medicine and making diagnosis and treatment, you can do a lot more damage than you can help. See somebody who's trained and knows what they're talking about.
Right.
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 Well, I will have to add, though, anything you read on the internet on our website is true.
I would agree with that. Yes.
Okay, we're just down to the last couple of questions. This one's a little bit long. I have a bunion on my right foot, which I've had for many years. It doesn't hurt, but the outside of the tip of my big toe feels numb. I recently associated it with my bunion. If I bend my toes, I can feel it in the tip of the toe. That bothers me more than the bunion does. A couple of months ago, I noticed a corn on the middle toe just below the nail. I didn't realize it was a corn. It looks almost like a blister as it's filled with fluid. Is this the beginning of a hammer toe? Should I see a DPM about this? That's like 4 questions all.
No, that's easy because that really relates to kind of what I started to talk about. People come in to see me, and they may have a hangnail, and they may have something very simple, and I'll look at their foot, and they have this giant bunion, and I'll do the exam, and I'll say, "Was this ever bother you?" I'll point to their bunion, and they'll say, "No, I've had it for years." Well, the reason it doesn't bother them is because they're wearing shoes that don't irritate it. Now, and not to make fun of anyone, but I have more patients that come in wearing clown shoes because they've either heard about bunion surgery, they don't want bunion surgery, and they'll say, no, that doesn't hurt. Well, to look at it, if you wore a dress shoe or a regular shoe, it wouldn't fit in the shoe, or it would definitely rub. So yes, if you wear sandals all the time and you have this giant bunion, it's not going to hurt because you're not putting any pressure on it. But realistically, the bunion is there, and if you've started developing numbness because the toe has turned sideways, you're getting into those later stages of a bunion, which, even though it doesn't hurt, it would hurt if you did normal activities wearing normal shoes. So it's not something to be ignored. The hammer toe is because of the same reason you have the bunion, the muscle imbalance that has occurred. If you don't mind wearing open-toed shoes or a shoe that nothing rubs on that particular toe, then that hammer toe, that corn isn't going to bother you. But what happens is you start to wear more sandals or more open-toed shoes or cut a hole in your shoe, and then when one toe starts to get hammered, then another toe starts to get hammered, and then another one. So in my opinion, why wait? Because, as I said, there's over 50 different bunion surgeries. The worse the bunion, the worse the surgery, the more complicated, the less chance of an excellent recovery. Not that everyone with the bunion needs to run out and have surgery, but you really need to go to a podiatrist that takes a series of x-rays and sits down with you and says, okay, here's normal, here's where you are, here's severe, here's what you're getting yourself into. And that's what I do with my patients. I say, if you said you wanted to have this fixed today, here's what we would do, and here's what you're getting yourself into. Everything from how much is it going to cost, to how much is it going to hurt, to how long is the surgery going to be, to how many stitches. I mean, I really try to cover everything as best I can. Most bunion surgery, I mean, I'd honestly say 75% of the bunion surgery I do, if people are taking pain medication past the second day, then there's a problem. It's such a common, really simplistic way of looking at it, and I would tell all the people out there, do not be afraid to ask your podiatrist questions. Don't be afraid to ask your doctor any questions. I mean, there's no stupid question. If they can't find the answer, then at least they'll go look it up, or at least they'll have something and then sit down and have a discussion, because bunion surgery is, in my opinion, is very simple. I do a fair amount of it, but it's something that needs to be explained, and you're not going to be back on your feet in 2 weeks. Most of the bunion surgery, these are, in my opinion, these are weight-bearing bones, and you're not bearing weight for about a month. Now, if you do everything right and you do follow your doctor's instructions, there's no reason by at least 6 weeks you're not back on your feet blowing and going. But, these are weight-bearing bones. You can't take them for granted.
Right. And just to invest 6 weeks to have it not hurt for the rest of your life seems worth it.
Yeah, especially if it's a later stage arthritic problem, which all bunions will become arthritic. And once they're arthritic, you're not dealing with correction, you're dealing with salvage. So there's a big difference.
Okay, we have one last question. This person's a runner and says, I have what looks like a neuroma, N-E-U-R-O-M-A, under my foot above the toes.
What's the question?
Well, it says they're a runner and they have what looks like a neuroma under the foot above their toes. I guess they're just wondering what your comment would be about that.
Well, you can't see a neuroma, first of all. Neuroma is an inflammation of the sheath or the covering of the nerve, generally between either the second and third or third and fourth toes. There's a stabbing sort of pain. Some people have electrical shock. Some people have numbness. But there's a place in the foot, in the ball of the foot, where that nerve is somewhat prominent. The irritation of the nerve being trapped between the bones and between a ligament, there's a confined space there. That space irritates the nerve, and when the nerve sort of expands, the nerve sheath expands, there's no room. So it gets very, very painful. Neuromas are pretty pretty common, fairly easy to take care of, again, conservatively. It's one thing in medicine that we do cure is neuromas, because neuromas can be removed, although, again, I usually attempt conservative treatment prior to any kind of surgery. But neuroma is just an inflammation of the sheath of the nerve in a confined space, and it gets really irritated. If you elevate the foot or use ice, you can shrink that tissue. You couldn't see the neuroma, but you could certainly feel it.
Okay, okay. Well, we've had a few more people typing in. Thank you so much. This is great information. One person said, wow, I've learned so much. I'm going to go find a podiatrist tomorrow. I wish I lived in Tulsa.
Yeah. Well, I'll tell you, if I give it some suggestions, you know, I'm a member of the American Podiatric Medical Association. I think podiatrists should. I'm also board certified in surgery. I don't think you should really see any kind of physician who isn't board certified or at least board qualified in their particular field. And again, don't be afraid to ask questions.
That's great. I guess we should have, when we were promoting this, said if you have feet, you need to be here. So
Right.
maybe we'll use that in the, you know, letting people know about the archive. So this is great.
Yeah. Yep. The MP3s will be available, folks, within a couple of days. Now, some of these are copyrighted, right, Mark? The slides.
Slides.
Yeah. Did you say something about them being copyrighted, or?
I've used some of my own slides, and some of these slides are copyrighted from the American Podiatric Medical Association and a couple of other societies. So I think they're pretty much licensed to. They're able to be used by licensed podiatrists who are members of the APMA. Yeah, so they all are copyrighted.
Right. But anyway, the MP3s will be available, so you can listen to them. And again, Mark, thank you so much. Yes, I will wake up at 5 a.m. tomorrow morning to call the gym and reserve the racquetball court.
You're a good man.
Well, we appreciate you. And folks, thanks for joining us. And there will be 2 webinars tomorrow, Tuesday, and Thursday. You have a great evening, and see you later. God bless. Bye.
Good night.